Thank you for kind introduction. Thank you, Chairperson, and good afternoon, ladies and gentlemen. This is my great pleasure to deliver a talk about NOACs, which is the emerging and established treatment strategy in stroke prevention and atrial fibrillation. The number of atrial fibrillation patients in Asia is expected to increase dramatically. For China, it is estimated that 5.2 million men and 3.1 million women aged over 60 years will have atrial fibrillation by 2050. And this number may be 2.5, 1 for men, 1.5 for women. Will be bigger than USA population atrial fibrillation patients. Excuse me. This is the first slide, excuse me. Despite prevalence being lower than in Caucasians, Asia has a great AFD's burden owing to proportionally larger aging population. The prevalence of atrial fibrillation in Asia is about 1% compared to the Caucasians, 2.2%. And these numbers will take over the USA atrial fibrillation population. Stroke is the leading complication of atrial fibrillation, and AFib is associated with a 5-fold higher stroke risk overall, and AFib is responsible for nearly a fifth to a third of all strokes and the leading cause of embolic stroke in atrial fibrillation. This is a Danish National Indicator Project study that included 39,000 patients hospitalized for stroke, including 6,200 AFib patients. Most 90% stroke associated with AFib are ischemic. Only 8% of stroke was hemorrhagic stroke. So we can assume that ischemic stroke is very important for the management of atrial fibrillation. Compared with other causes of stroke, stroke in atrial fibrillation has a heavy burden of morbidity and mortality, and is usually more severe, likely to be disabling, and has double the post-stroke mortality rate. Stroke risk in Asia is still increasing over the past decades, 5 to 8-fold greater in patients with atrial fibrillation versus patients without atrial fibrillation. This stroke risk rate, the magnitude of increased stroke risk is similar or at least similar or higher than that in Western countries. One of the most widely used drug of the 20th century may be the aspirin. The aspirin has been taken by millions of patients worldwide for the treatment and prevention of cardiovascular disease and the most widely tested antiplatelet drug. And it is still and has been used to stroke prevention in atrial fibrillation. It has been considered safe, but it is proved less effective. It is still used to alternative drugs to VKAs when anticoagulation is contraindicated, or for using in patients at low risk of stroke. But we know that this is not consistent with the latest treatment guidelines of atrial fibrillation. Aspirin inhibits platelet activation and aggregation. Aspirin does not exert its antithrombotic effect through the coagulation cascade, which is a very important role in the thrombus generation in atrial fibrillation. This slide shows a lot of aspirin's limitations. It shows a limited efficacy for stroke prevention versus vitamin A antagonist. No evidence for reduced mortality with aspirin in atrial fibrillation, and it also carries a significant bleeding complication with its use, and still it has a significant adverse effect. Despite of this limited efficacy, the aspirin has been used for the prevention of stroke and thromboembolism in atrial fibrillation. Only a SPEP trial showed the superiority of aspirin to the placebo in major clinical trials. And also aspirin was inferior to warfarin for stroke prevention in atrial fibrillation in a lot of clinical trials. And it also carries a significant bleeding complication, including intracranial and major bleeding. Its rate is not lower compared to oral anticoagulation therapy. So current guidelines, 2016 APCIS guidelines says antiplatelet monotherapy is not recommended for stroke prevention in atrial fibrillation patients, regardless of stroke risk. And also, 2014 APCIS guidelines on the management of atrial fibrillation say do not offer aspirin monotherapy solely for stroke prevention to people with atrial fibrillation. This slide shows treatment current trend over the past 2 decades. Two of the most important changes has been made. One is thromboembolism prevention. Is another changes as atrial fibrillation catheter ablation. Warfarin has been introduced in 1970s, and in early 1990s, warfarin showed the better efficacy compared to placebo and become a mainstay of treatment of thromboembolism in atrial fibrillation. But vitamin K antagonist has a very narrow therapeutic window. We have to keep INR between 2 to 3 to show its effectiveness. If INR becomes below 2, the stroke rate increases. If INR becomes above 3, the intracranial bleeding complication increased. And another drawback of the warfarin therapy is keeping an INR within therapeutic range is very challenging and difficult, especially in Asian population. This slide shows a poor INR control in many studies. Poor INR controls increased risk of stroke. If this slide shows no treatment, the dotted black line shows no warfarin treatment. If we keep INR, TTR rate, if it becomes below 50%, the complication rate will become higher than no treatment. So keeping INR above 60% is very important. And warfarin carries a substantial bleeding risk in especially in elderly population above 65 years population in the real world. From these evidences, we can assume that vitamin K antagonists still have a very lot of limitations. Slow onset and offset actions, subject to multiple food and drug interactions, and anticoagulation reversal may not improve outcomes, and variability in dose response between individuals. Limitations of a vitamin K antagonist and this aspirin have prompted the search for alternative antithrombotic drugs. We must have those drugs, the comparable efficacy versus vitamin K antagonist, risk of bleeding, superior efficacy versus antiplatelet agent. We now have 4 different kind of novel or new oral anticoagulant: dabigatran and rivaroxaban, APCIS and ASA. Dabigatran is all these drugs show the better efficacy and less complication rate. I will introduce 4 different kind drugs. These 4 different drugs showed at least better efficacy than warfarin in the prevention of ischemic stroke, at least comparable efficacy than warfarin, and especially in the prevention of hemorrhagic stroke. All these drugs, 4 drugs, have proved in the beneficial in the prevention of hemorrhagic stroke. That means very safe than warfarin in the management of atrial fibrillation complication. And in terms of the major bleeding, APCIS and ASA show the superiority than warfarin, and dabigatran and rivaroxaban had a similar bleeding complication than warfarin. This slide shows antithrombotic therapy global use in 2014 from the GARFIELD registry study. About 70% of patients receiving treatment. United States, about 50%, and in China, only 10% oral anticoagulation therapy. But nowadays, in this year, 2017, the GARFIELD-AF registry showed that the anticoagulation treatment strategy is evolving and changing. The use of NOACs has increased at all levels of risk. However, still, vitamin K antagonists are still widely used. So, from this GARFIELD-AF registry, we can assume that the NOACs will replace the vitamin K antagonist in the next few years. This slide shows the expectation of a global anticoagulation market in the future. In 2013, only 20% of patients received direct thrombin inhibitors and direct factor Xa inhibitors for the management of atrial fibrillation to inhibit complication. But in 2018, the market share of the direct thrombin inhibitors and direct factor Xa inhibitors may have 50% of the market in the prevention of a stroke in atrial fibrillation. Thank you for your attention.